our board chair, Gary Renville, who has also joined today's call. First and foremost, at CJA, our mission is to connect and equip communities with the tools to improve health equity and well-being. And, today we're just so happy to be able to partner with RIP, Medical Debt, and our CJA communities, who will share a number of policy opportunities and ways to increase awareness in our communities. Before they share their formal presentation, I did want to share just a few staggering statistics. And these stats come directly from a recent Forbes article where a survey was taken and they highlighted the following. 25% of survey respondents indicated that they had unpaid medical bills on their credit report. Of that 25%, 90% have experienced financial setbacks as a result of medical debt. In that study, they also found that 88 billion in medical debt is listed on Americans' credit reports. And medical debt is also a top consumer complaint to the Consumer Financial Protection Bureau. 4 out of 10 individuals reported difficulties in paying off medical debt, and 62% of those survey respondents think that removing medical debt from their credit reports will improve both their mental and financial health. So very staggering statistics, and we know that addressing these issues require changes on multiple levels. So today, you'll hear from the experts at both RIP and the experts in our CJA communities, who will provide examples to help us move forward from beginning to conceptualize those policy changes, to sharing ideas for us to implement in our communities. Finally, we're really grateful for this opportunity to work together and to share lessons learned from our members and new innovations that each of us can take back to our organizations, states, and communities to make a difference in addressing medical debt. Back to you, Gregory.
Thank you so much, Quentin. And again, in partnership with Communities Join in Action, we've also, from the first learning call, have our partners on the call from Access Health. So I want to bring on Ms. Vondi Woodbury to kind of share some updates from the first learning call on the work that they've been up to, as well as to just reiterate some prompting and objectives for the call. Ms. Vondi Woodbury is a founding member and past board member of CJA as well. So Vondi, if you wouldn't mind coming off mute and just introducing yourself.
I don't think I'm muted, am I? All right. Thank you, Gregory, and welcome everybody. We're excited that you're here to learn more about medical debt, and on this second of a series of calls that have been sponsored by Communities Joined in Action, RIP Medical Debt, Access Health, and DuPage Health Coalition. I'm going to start with a few updates on what we've been doing here in Muskegon, and then move from there to reminding you on some of the things that you ought to be thinking about as we go through the call. So Muskegon is in Michigan, if you didn't know that. And we here in Muskegon, we have been participating in one of the grants that has gone through CJA to communities to see just how far communities can address the issue of medical debt. And from the community perspective, it is a tangled web, I must tell you. Here in Muskegon, we are addressing it by, first and foremost, we have convened a community team that was formed during our 100-day challenge, which is an annual planning gathering that we support here in the community. Our team is planning a community forum. One of the things we have learned about medical debt through a series of focus groups that we've done is that there is a great deal of misunderstanding and frankly, ignorance about medical debt. People don't know what to do. There's a great deal of stigma attached to medical debt. There is a lack of understanding about resources like financial assistance. And so our feeling was, well, let's get as many folks in town in a room and let's start to talk about medical debt and what we can do about it. So we're pulling in resource people from our hospital, legal aid, our court system, and many others who work with folks who have medical debt to address the issue. It's estimated that in our community, somewhere between 17 and 18% of our residents are in collections because of medical debt. That is a huge number. And as you think about that, especially those of us who have been doing access to care processes, one of the things that we are always aware of is when things like that happen, folks avoid care, as well as there's sort of this additional impact on social needs. So one of our top policy goals is to work with our safety net providers and our hospitals and the FQHCs to add a question about medical debt on our social determinant of health assessment forms. Most of us don't do that. And one of the impetus for this, I mean, besides the fact that we all should do it, is that there is more attention given today on doing those assessments. CMS has now mandated that hospitals must ask at least 5 questions on social needs. And the Joint Operating Commission also said pretty much the same thing, but as an example they gave, one was on medical debt. They didn't mandate it, but here's an opportunity in terms of policy to really work with hospitals and to talk to them about how do we collect that data? Because as you all know, one of the most important things we can do is gather data. Our national data, of course, tells us that there's a great correlation between medical debt and food and housing insecurity. There's plenty of research out there. And we hope to improve our understanding and address one of the impacts of debt, medical care avoidance here, because that is also a big issue. Through our focus groups, we talked to people who said they absolutely were avoiding going to the hospital, going in for medical treatment. People told us that they are fearful of debt. They never talk to anybody about their debt. So there's a lot that we have to move through to really get information out to community and have them open, in fact, to beginning to respond to things that they can do. So working with RIP, we've identified some really tremendous resources. We're going to be aggregating those and creating handouts for people in our community. And that really, if we think about it, that's going to be our first step, because after that happens, then we think we can really, really begin to address some of the policy issues that affect those of us here in Michigan. Having said that, getting back to our call, there are several objectives, and hopefully you've looked at some of these materials, but I want to remind you about the objectives of these calls. First of all, this call is to share trends in federal and state medical debt policy development. What's changing? What's going on out there in the field? And what might this mean for CJA members in your communities? Second, we want to discuss strategies. What are the sorts of things that you can do at the community and regional level, like CJA members have used to do to ignite public information and attention around things like access to care? This is an access to care issue. We need to embrace it as an access to care issue. It isn't something that's off there in the perimeters. This is something that affects all of us who really began to work with CJA and create CJA to address that very specific issue of access to care and making sure that people get medical care when they need it. And finally, we want to hear from all of you about the opportunities you may see locally, regionally, and draw broader attention to medical debt as a systemic issue. What are the ideas you have? What challenges are you facing? And what are you anticipating you might do? So we're anxious to hear from you. And with that, I think I turn it back to you, Gregory.
Thank you so much, Mandy. A lot of exciting updates coming out of Muskegon, and we'll be continuing to also provide updates in our newsletter, which we'll have a link to at the end of the call. But with that, I wanted to transition to our panel today, and we have our panelists on. I would just briefly introduce Eva Marie Stahl is going to be presenting. She's our Vice President of Public Policy at RIP Medical Debt, as well as Lindsay Zickdale, our Policy Analyst at RIP Medical Debt. So Eva and Lindsay, if you wouldn't mind coming off mute and taking away the presentation.
Sure. I always feel like we need Price is Right music or something to really, get it going at the beginning.
There we go. Good afternoon, everyone. Thank you for moving the slide, Gregory. So we'll get started. Again, my name's Eva Stahl. I'm going to start us off and talk to you a little bit about just an overview of what really Quentin and Vondi both already highlighted about medical debt, and then talk about some of the things happening at the federal level and some themes that we're seeing emerge at the state level, and then pass it on to Lindsay, who's going to talk about some of our polling results, as well as some community strategies that people can consider. So just a quick note about who we are at RIP Medical Debt. We are a nonprofit entity that purchases debt in bulk and matches that debt purchase with donor dollars. So we leverage those donated funds to purchase debt for pennies on the dollar. We have two criteria. One is that we purchase debt for people that earn at or below 400% of the poverty level, or their debt is more than 5% of their income. So it's a really exciting return on investment that we're able to help people in the moment. But we also recognize that we need to do more than that. So we listen to our storytellers and our beneficiaries to really elevate their lived experience so that we can influence upstream policy and address root causes. Next slide. So let's just do a quick overview and reminder for folks. This is relatively fresh data, but it seems to be somewhat the same particularly over the past the last 2 years or so. So medical debt is really pervasive, right? The Kaiser Family Health Foundation did an analysis looking at some census data and really came to the number about $195 billion in medical debt across the country that affects over 100 million people. It's a lot of people, it's a lot of debt. We know that 1 in 4 people are struggling with their medical bills. This chart gives you a little bit of an overview of, you can see how people are managing it, whether they're borrowing from friends and family, or they just, a quarter of them can't even really pay at all. Next slide. We also know that this causes people to avoid or delay getting care. As Vondi noted, that this is something that we're really worried about, is that if people have unpaid medical bills or medical debt, that they don't return to their provider or they seek out a new relationship. And we know continuity of care is so important. You can also see it causes a lot of mental health and distress for people. It really increases their anxiety and just creates a whole host of harms for people. Next slide. We also know that while the uninsured really struggle with medical debt the most, if we look at the sheer numbers, we also know that privately insured people do. So just because you have insurance, it doesn't mean that you are protected from medical debt, right? So we know that it's a wonderful thing, and we're really excited about the increasing numbers of people that can access health insurance. But we also know that some health insurance is not as comprehensive as people need it to be. And particularly for lower income people that are working people and getting their health through health coverage through high deductible health plans that place a lot of financial responsibility on the patient. It's extraordinarily difficult for them to afford those deductibles and out-of-pocket costs. Next slide. We also know that health status really matters, right? We know that people that have medical debt also tend to need more health care. And that's really problematic as we think about the fear about returning to a provider or delays in care, that's something that we don't want to see, particularly for people that are managing a chronic illness. Next slide. And of course, we know that there are deep inequities when it comes to medical debt, that it's disproportionately represented in states that have not expanded Medicaid and in households of color, particularly Black households, as this map shows. Next slide. So with that quick overview, let's pivot and talk a little bit about, well, what's been happening over the past couple of years with medical debt, because certainly it's all over the media. It's becoming a sort of a common conversation among neighbors and in people's households, and the federal government is responding somewhat. So in 2022, things sort of kicked into gear when the Consumer Financial Protection Bureau really decided to take this on as an issue that they wanted to focus on. And in January 2022 was also the month that the No Surprises Act went into effect. And so when it did, the agency let collectors know that they had certain responsibilities under the No Surprises Act, meaning that they couldn't pursue surprise bills, and they needed to recognize their role in that. By March, the Consumer Financial Protection Bureau released a pretty comprehensive literature review and report on medical debt, and launched a webpage so that people could have access to both research, information, and direct consumer appeals. In that same time frame, the national credit reporting agencies, and sort of reading the tea leaves, decided to voluntarily change their medical debt reporting. meaning that for bills under $500, they would no longer show up on your credit report. This was a really exciting move for people and sort of signaled that the credit reporting was really a pain point for patients. By April, the vice president announced a series of changes to medical debt and had a public event to acknowledge the interest of the administration in tackling medical debt. And by December, Senators Murphy and Van Hollen decided to re-release their medical debt bill. And this medical debt bill created some guardrails for hospitals around financial assistance, but also some reporting to the Consumer Financial Protection Bureau, in addition to some data collection requirements. Next slide. In March of this year, advocates began to petition the Consumer Financial Protection Bureau regarding the credit reporting, noting that this voluntary action had been taken in 2022. They really want to see it institutionalized and began a petition noting that Consumer Financial Protection Bureau had the power to do so. By April, they released a report on medical credit cards and how people were financing their healthcare bills. So it's important to note that something that we all do all the time and is pretty typical is that people throw out their medical bills on their credit card, right? And this, it's no longer medical debt, it's financial debt. So recognizing that this was a problem and could be challenging for particularly people that are struggling with unpaid medical bills, really thinking about the tactics used to offer these types of payment products was concerning to the Consumer Financial Protection Bureau. By August, the White House announced actions to lowering healthcare costs and had a public event really noting the importance of the No Surprises Act, along with introducing the idea that people should not be using credit cards to finance the bulk of their medical bills, and creating an opportunity and a platform for Treasury and the Centers for Medicare and Medicaid to come together with the Consumer Financial Protection Bureau and request information from folks in the field, both practitioners as well as advocates, about what should the Consumer Financial Protection Bureau do about regulating credit card products in a medical setting. By September, this request for information period closed, and almost simultaneously, the Consumer Financial Protection Bureau pivoted to propose a ban on medical debt on credit reports, following up from that March advocacy effort of the same year. And by October, Representatives Porter and Senator Merkley introduced a bill to ban medical debt on credit reports writ large. This is actually very similar to the Consumer Financial Protection Bureau proposal, but it was just putting it in legislative language. Next slide. So what are really some themes here? I mean, really, we know that the administrative actions are, they're limited, but we know that there is a lot of activity at the administrative level, and there's a lot of interest, in tackling medical debt. So we see the Consumer Financial Protection Bureau really has taken center stage and really from the very beginning, affirming responsibilities related to the No Surprises Act, but also really engaging actively with other agencies, most notably when the Vice President made her announcement in 2022 around Health and Human Services, Veteran Affairs, and other agencies to really take note and really remove medical debt, not from credit reports per se, but from being considered when people were seeking loans and borrowing funds. So those federal loan entities could no longer take medical debt into consideration if it was on a credit report, which was really important because we know that the research tells us that medical debt is not a good predictor of someone's creditworthiness. And then in that same beginning of the year, when the National Credit Reporting Agencies voluntarily took action on medical debt, we could see the momentum really building, and we continue to see that as the Consumer Financial Protection Bureau makes an effort to make that proposal or that voluntary act something that's institutionalized and formalized. And certainly medical credit cards have continued to come to the forefront and be of interest both to the administration, but states as well. Currently, there really is no bipartisan legislative momentum yet, but certainly it's percolating, and we'll see when we move to the state section how that is beginning to get momentum at the state level. But there's certainly a lot on the horizon. So there's a lot of activity and interest from congressional members as well. There was a letter that was led by Senator Warren earlier this year to the IRS requesting data on hospital compliance with financial assistance requirements. sometimes called 501R. And there was a white paper released from the Senate Health, Education, and Labor Pensions Committee called the HELP Committee. Even though some of the recommendations were outside the jurisdiction of this committee, it really elevated the issue and concerns around people being able to access financial assistance. And then the bill to ban medical debt on credit reports introduced October reinforces the actions of the Consumer Financial Protection Bureau. Next slide. So that's a lot on what's really happening at the federal level. It's been a really busy couple of years as the federal government and different players and stakeholders at the federal level try to navigate what they can and cannot do as they seek out solutions to mitigate the harm of medical debt. There's been a lot more activity on the state level. Next slide. So states are really active and they're enacting different medical debt protections. This slide really just walks you through a number of different examples of where states have been active. So some states are setting eligibility floors for financial assistance. So instead of giving hospitals the ability to set their own floor for eligibility, they might set a standard floor across the state, either 200% of the federal poverty level, for example. Some states are mandating screening for financial assistance, and that hospitals be more proactive in this effort. Some hospitals are being required to offer financial assistance regardless of their status. So currently, with respect to federal requirements, this just falls to nonprofit hospitals. Some states are including for-profit hospitals in that requirement. Colorado is the first state to prevent medical debt from showing up on credit reports, and there's legislation pending in other states like Massachusetts. Other states are banning civil arrest, wage, and bank account garnishments and foreclosure. These are often referred to as ECAs, or extraordinary collection actions. And other states are limiting how much of your income can go to paying medical debt. So trying to better protect people's monthly cash flow by limiting either by a percentage or by a time period. Some states are capping, back one more, Gregory. Well, some states are capping interest rates on medical debt or creating categories of automatic eligibility for financial assistance, which can be really helpful. So there are tools around presumptively screening people for medical debt, but there are also ways to just acknowledge that if somebody's enrolled in a public program such as SNAP or WIC, that they would automatically access financial assistance. Next slide. So the next couple of slides are just going to give you a little bit of a snapshot of where this activity is happening. So these are all drawn from a really great report that I highly recommend that was funded by the Commonwealth Fund, and Manasa Kona from Georgetown University compiled all of this research and keeps it updated. And so you can actually look across a number of these different provisions on the previous slide to see which states have actively passed legislation or adopted these provisions. So this is really about setting financial assistance policy standards. You can see that it's a little bit scattered across the country, but a number of states have engaged in this policy, at least 19 states plus DC. Next slide. Here's a snapshot of the limits on liens and foreclosures to collect medical debt. So you can see that she's separated out by unlimited homestead exemption, prohibits or limits ability to place lien or foreclose homes, or limits foreclosing on homes, but not on placing liens, right? So it varies in what the provision does, but it's also an active area of policy. Next slide. Here's just the beginning of what we see as a really active conversation around limiting credit reporting of medical debt. So even at the federal level, as there's action being taken both by the Consumer Financial Protection Bureau as well as legislative efforts, you can see that states are picking up on this and proposing legislation. And I think we'll see this map shift quite a bit next year. Next slide. Here are state preconditions before a hospital can send a bill to collections. We know that the workflow process around bills is really complicated and can be challenging for hospitals and quite intricate from beginning to end with different rules. This really is about trying to create some standards before revenue cycle can, move it to the debt collections process. And there are different guardrails by state, but some interesting policy ideas. Next slide. So really there's momentum for policy change at all levels. I think that you can probably see, and Lindsay's going to spend some time talking to you a little bit about some of the community strategies and things you can think about even at the institutional level. I would say that it's all important and we should be doing not or, but and all of these things. At the state level, you've gotten a little bit of a snapshot of what's happening across states and various efforts to pass policy to mitigate the harm of medical debt. Notably, expanding Medicaid is still a number one on the list and probably the lowest hanging fruit to mitigating the harm of medical debt at the state level. And then at the federal level, there will be a continuing conversation about medical debt, particularly as we move into a year when the new enhanced subsidies for the ACA marketplaces are set to expire. We anticipate an increase in conversations about coverage and high out-of-pocket costs, and prescription drugs has continued to be a big part of the conversation this year that will travel into next year. So medical debt will continue, I think, to be woven into those conversations, but also create new opportunities to have conversations about how we can strengthen things at the federal level. And we always make a pitch for don't forget data. Vondi, I hear you on that one, which is really important. So with that, I will pass the baton over to Lindsay. Oh, wait, I shouldn't do that yet. I will do one more slide, Lindsay.
I'll hand it back. There you go. Yeah.
Okay, you hand it right back. I'll hold on to it just a second. So I think where we've ended up as an organization, and we're happy to have a conversation about this today, is that there are really three main domains where we look to advance policy and have conversations and influence policy, honestly. So the first, of course, is comprehensive affordable coverage, as we just talked about, that high out-of-pocket costs are really problematic, certainly for a large portion of our population and a bulk of the stories that we hear about. We also want to make sure that we have clear communication about an enrollment in financial assistance programs, and that there's still a lot that can be done at the institutional level as well as the state and federal level to ensure that. And finally, banning extraordinary collection actions that you saw on this slide, that some states have done this to really protect people and their credit and make sure that they can economically thrive. So that's where we have landed. And now I will pass it on to you, Lindsay.
Thank you. So medical debt and public opinion. Everything that Eva has touched on really is informed by and grows out of, in large part, people, the general public opinion on medical debt. So diagnosis debt was started by KFF a few years ago, and it's really been a leader in these stories, putting a human face on, this is what medical debt is. This is the experience. We can go to the next slide. We recently did, next slide. And if I'm talking too fast, somebody raise a red flag or something, because I can really zoom through. So I'm going to look to you, Gregory. So we recently did some survey work with Perry Undum and two of the major cancer groups that really tracks with a lot of what we've already touched on today, right? With the KFF surveys. So nearly half of people surveyed said they feel trapped by their medical debt. And almost as many said they thought they'd never be able to pay it off. So they're just very much resigned to this fate where you have this debt hanging over your head and you don't know what to do with it. And you can see on here, I'm not going to read you the whole thing, but a large percentage of people also felt shame or embarrassment over having medical debt. Next slide. However, there are also some really, I would say, sort of not strangely optimistic, but things that give me hope. So medical debt is really unique in that it's the only kind of debt where the blame is placed on the institution rather than the individuals. So you can see here, 86% of people agree that usually it's not the people who are to blame. The problem is really the health industry that prioritizes profits. And in our current political environment, it's really worth zeroing in on something that has that much support. That's almost unheard of. So it really serves as this foundation that we can build our policy efforts, state, local, federal upon. Next slide. And most people struggle with high healthcare costs and bills they can't pay. They're afraid and have to make tough decisions, which again, we've also touched on. So you're making trade-offs, almost 70%, 65% are making trade-offs to afford healthcare. They're delaying dental care, skipping doctor's appointments. They're having to make difficult choices at the grocery store. Almost everybody is concerned about going into medical debt when they use the health system. And that's really not what we want. You want to be able to go to the doctor to heal, right? Not be afraid of your future financial health. And 1 in 5 avoided going back to the same provider where they owed money because they were afraid they would not be treated. So you can see in these key findings that people are really concerned about medical debt and it's influencing the choices that they're making that over the long run have a significant impact on their health and wellness. And it's just incredibly common. It doesn't really matter what strata, what socioeconomic strata you're in, there's somebody there who's having this experience. Next slide. So community strategies. How can we take this information, which can feel heavy or confusing or sometimes very negative? How can we take that and turn it into actionable goals, ways to change the system, move things forward? I know this is a very stereotypical looking graphic, but if it works, it works. So CJA knows this better than most, but it's always worth repeating. Community work really plants the seeds for that long-term policy change. I'm reading Braiding Sweetgrass right now. I don't know if anybody else is reading it, but I really just love this idea that local level policy and community work, it will just eventually grow into this tree that covers everyone, right? Like a successful society is somebody who plants trees, not for themselves, but for the future. So questions for you as advocates to consider. Legislative change can be frustratingly slow, sometimes taking years or even decades. And it's very normal to want to jump straight into the, sometimes exciting work of drafting bill language or testifying at the Capitol. But real lasting systemic change is grounded in the needs and insights of the community. So a few questions to consider. What are your guiding questions and principles? And this is a really important first one. Are you committed to elevating the voices of people with lived experience? What questions are you wanting to tackle? How are you listening to your community? Are you going to where they are? Are you asking for them to come to you? These are some of the kind of nitty-gritty things that sometimes get lost. What's your ultimate goal? Is it working with the hospital to improve financial assistance policies, or is that just a piece of a larger goal down the line? And do you want to ensure that everyone in your community has access to affordable, person-centered healthcare when and where they need it? And again, what are your most pressing healthcare needs? Is it a mental health clinician shortage? Are you unable to find those? Is it a shortage of general practitioners? We've spoken with beneficiaries who live in parts of the country where there just isn't a provider. So they end up going to freestanding ERs, and then that costs you $1,000, even though they're just checking your blood pressure. So there are these very discrete, not necessarily easy to tackle, but it's a very black and white problem that you can bring your community together to figure out how to address. And then finally, and I think this can often get lost too, what do you like about the healthcare system in your community? Is there a strong social safety net program, maybe a mobile crisis outreach team or a nurse-family partnership that community members want to lift up and grow? I find that it's very helpful to have, at least one thing that you do like that you want to make bigger so that people feel more collaborative, I would say, and less negative, less like everything's broken. Here's something that's working. How can we make it bigger? Next slide. Questions continued. Looking beyond healthcare, what other needs are not being met? Are people missing doctor's appointments because they lack transportation? What is the bus system like? How many people are experiencing food insecurity or unstable housing? All of these other social determinants of health that feed into accruing medical debt, right? What kind of insurance is offered by the biggest local employer? And is that coverage robust enough? Is there a way to have a conversation with these employers to sort of work to build out more robust benefits? Other sort of, again, I hate to use the term easy, but I'm blanking on something better. So we're going to go with it. Other easy wins, how well do community members understand their rights when it comes to healthcare? We see that generally it's not very well because it's kind of confusing, or it feels like you're playing a game and you need to know the right words to say in the system. Do people understand when and how to contest a bill? Do they know that they're supposed to get a cost estimate prior to services? Are there existing local, state, or federal laws that you could create information campaigns around so that you don't necessarily have to reinvent the wheel? You just need to help people know that the wheel is there. Then you know your community best. What do you want to know before implementing a new program, intervention, or policy to address medical debt? And so then some examples on the next slide of community interventions we can explore. Identify and train issue champions. They can speak with the media or other stakeholders about the needs and gaps or solutions for medical debt, or any issue. It can be like traffic lights, it doesn't matter. Hold listening sessions with community members and leaders and really delve deep with questions designed to understand people's experience, which Access Health has done with their focus groups, right? What solutions do they suggest? How are you listening? Are you coming with solutions you sort of want to fit onto the community, or are you letting the community inform what solutions would work best for them? There's a back and forth. take potential solutions to decision makers, meet with hospital leaders and other partners, work with the local hospital to create or strengthen patient family advisory councils. I worked with a hospital at a previous job here in Texas that had a really strong PFAC, we called it, and they were, it was really wonderful because they were able to inform efforts to become a fully trauma-informed care institution. And that's, you know, something very rare to see. Encourage the creation of subcommittees maybe focused on billing and affordability. You can do things like community resource mapping. So come together with other orgs like FQHCs, financial coaching orgs, and really map out like, oh, well, I have these programs and you have these, and I have a lot of clients who need that. So you can really get a good picture of the actual existing resources in your community and start to break down those silos. And then, go back 1 second. This is something that Access Health, again, is already doing. Advocate for including medical debt and affordability in assessments. Include it in the local community health need assessment so you can really get that data that is so hard currently to get our hands around. Okay, next slide. So now what? Listen to what your community is telling you. Lived expertise is the foundation of future work. Understand the resources that already exist. Don't reinvent the wheel. Understanding what you have will help you identify what you need. And then finally, map out your strategy for engaging people in conversation. How you approach these conversations will impact the information you get. So meet the people where they are and don't be afraid to think outside of the box. And I think that's my last slide. So I'll stop there.
Thank you so much, Lindsay and Eva. I know for reference, the slides will be sent out after the call, so it'll be part of the follow-up. So these will provide the resources that you can, that members can access after the call. We have about 10 or so minutes slated for discussion. And we wanted to see any questions that, you know, immediately arise, or any ideas, or even just discussion points that people wanted to delve into, given the presentation and kind of digesting everything that we walked through. I wanted to, before we do, I just saw one thing, and Eva and Lindsay, I wonder if you could speak to it, just because we've been talking about it a lot, which is that the progress that we made, or that was made, with the ways that CFPB is highlighting the role of just medical debt affecting your credit, but then the barrier to also having people know that it's not impacting their credit. Would you be able to just speak to the significance in having people understand that the debt, you know, that there's a mismatch between people even understanding the ways that the medical debt may or may not affect them?
Sure. So I think there are, first of all, I think that the results that we've seen so far, and we can share and follow up to, that the Urban Institute started to just take a look at what the effects are for taking medical debt off people's credit reports. And it's proving to be significant for people. We know that it's really harmful to have medical debt on your credit report. I think that for people to understand both that this is happening and that it should be removed, particularly in some circumstances voluntarily, even as we're waiting for something more formalized, either through legislation or from the Consumer Financial Protection Bureau, is that people need to also be thinking about how they're paying their medical bills. So going back to that point around why the issue of credit cards continues to come up, is that once people put their medical debt or their unpaid medical bills on a credit card, it's no longer medical debt. And so that financial debt will still show up on your credit report. So as you're making decisions about how you prioritize and pay your medical bills, it's important to understand that when you pivot to using something in the financial sector, that you've lost some of the protections that might begin to evolve and be strengthened in the medical debt space.
And I would hit on one more thing, Gregory, just anecdotally. I see a lot of people not understanding that it's $500 and under. I see a lot of comments from people saying it's all medical debt. And that's maybe where we want to get, but it's not there yet. So I think that's an important point to drive home as well.
Thank you.
Still work to be done.
So I wanted to take some time, considering that so this is our second learning call, and for those who were not part of the first learning call, we kind of dove in depth on what the partnership with our community partners have been, with DuPage Health Coalition and with Access Health, to kind of show the templates that or to show an aspiring template of what this work can look like in your community. Was there any questions, or was there anything coming up even just in your experience with what you're seeing with patients, or any trends that you're experiencing in your institutions, or anything that you think other CJA members, putting it to the call if anything came up, or if there was anything unanswered, or any other further observations that people are seeing in their local communities. I would encourage, either if you feel comfortable adding to the chat, or coming off mute. We would love to hear from anyone who's interested or wanted to share.
I guess I'm curious. This is Kara from the DuPage Health Coalition. Question is for Eva and Lindsay, but if there are others that can weigh in, welcoming that too. When you look at the states that are making inroads in terms of having more progressive policies around financial assistance or protections for consumers, are there themes that emerge as far as what is causing those states to be more friendly to consumers in terms of protection, lessons that we might take in terms of strengthening or encouraging that in states where we're not seeing that kind of behavior, or ways to bolster early signs of progress in communities where there's evidence that that's happening?
So it's interesting you asked that question. I mean, I think it's a little bit popcorn style, right, as we've seen across some of these states. But I think one thing is very true, which I think my colleague Jessica Curtis would affirm, which is that a lot of these states where some of these policy changes have occurred have happened over time, and really are often the result of a robust sort of community-based movement and infrastructure that has really elevated the issue of medical debt for a number of years, and really built momentum. I think Colorado is a really good example of that. I think probably Washington and Oregon as well. But it's also interesting to see states that have been less active be new entrants. And I think that there are different and interesting vehicles through which they can do that. So Arizona, for example, chose to do a ballot measure, right? And it had over 70% support for that ballot measure, right, in that state, which is pretty interesting because it's a different kind of state than, say, a Massachusetts or a California. But there was really strong bipartisan support for capping interest rates on medical debt. So, and using a different strategy, they decided to dive in through a ballot measure. But even in the issue that we've seen emerged around Massachusetts introducing legislation around banning medical debt from credit reports, they have been less active in the legislative space, but certainly I think a lot of states are seeing that as a clear starting point. It's something where there's a lot of support, and people feel like, yeah, that makes perfect sense. Let's do that.
Eva, I'm wondering, and if anything arises, but I see the opportunity to kind of shed light on the evolution of this conversation. And again, the impetus for the first learning call was to kind of engage the CJA membership around the work that we're doing, RIP Medical Debt, and again, DuPage Health Coalition and Access Health, and what we're doing on the ground and in policy domains. But we were slating this towards the end, but I wonder, Eva, if you could speak to the work that we have in the pipeline with CJA and the RWJF grant, only because it's another facet of the kinds of ways that we're probing this issue from different dimensions. And I'm wondering if you see that as an apt plug just to discuss that work just a little bit high level, just to share out, because we will be re-engaging through that work and through that grant that we secured.
Sure. So thank you for that. I think that as Lindsay highlighted in her presentation, you saw, and I think Gregory put it in the chat as well, that we had this really great opportunity this year to work with the American Cancer Society, their Action Network, as well as Leukemia Lymphoma Society, and a messaging firm that we decided to dip our toe into really understanding and get a sense of how people are feeling about medical debt and their experience. And we did this national survey. And it had some really profound results, which I think are reinforce our commitment to really getting the strategic messaging right, but also trying to continue to make medical debt a visible and important issue, both in the media, but just at large. So the next step in doing this for us is to engage providers themselves. So really thinking about how do providers feel about medical debt, and how are they engaging in these conversations with patients, if at all? And what is their sense around the issues of access and communication that's happening to them in real time? So we have an opportunity funded by the RWJ Foundation to the Robert Wood Johnson Foundation over the next year to explore this issue. So we are going to be reaching out to the CJA network to help participate and engage in this process of listening, understanding the experience of providers, and then pulling that information and data together through focus groups to formulate new strategies and tools for providers to become more robust champions in this space, which can look a number of different ways, as Lindsay highlighted in her slides, whether it's within the institution, within the community, or more broadly to influence conversations that influence decision makers and a number of different stakeholders. So we're really excited about doing this work. I think that it's important to include the provider community in the conversation around medical debt. We had a colleague the other day actually that did a webinar on patient trust. As we think about how that relationship between provider and patient could be disrupted by lack of trust due to unpaid medical bills or fears about being able to pay medical bills or return to that provider. So those are certainly themes that we'll be exploring over the next year.
Thank you, Eva. I think it's also super, like something that RIP Medical Debt does really well and learned really early was how important it is to engage people, the beneficiaries of our work, but also the people that are experiencing medical debt. But I think this is a really prime opportunity, especially with the CJA network, to kind of flip it and do individual engagement with the physicians, because we've been focused on the institutional level, whether it's the community health collaboratives that we're working with, the donated care networks, or if it's the hospital institution that we're working with. So I think it's just an exciting evolution in the work. And I know that CJA is a thought partner in that, and that we're super excited for the next year in working on that. And we'll be providing more on that, and we'll have the link to the newsletter that's in the where you can keep updates on that. But thank you for sharing that, Eva, because I just wanted to take the opportunity to not only show how this work is evolving in partnership with our community partners, but also by way of different ways that we're kind of engaging the different faces of this work. I wanted to share if there was anything else, before we can close the discussion. We have a few just closing items that I wanted to segue to, but before we do, I just want to make sure if there's any questions or any thoughts or any reflections are welcome. But included as well, we'll be sending out all the resources following the call. So with that, I would just take one moment. I wanted to transition to closing our call, and I wanted to actually ask our other community partner. We heard from Access Health at the start of the call. If we could bring actually Kara Murphy on, the president and CEO of DuPage Health Coalition. And if you could, Kara, if you wouldn't mind, again, building off of the first learning call, just any kind of updates or thoughts that you've been, that you've had on the progress you've been making in the work you do around medical debt. And then also just kind of bringing around the closing of the call.
Absolutely. Thanks, Gregory. And so nice to see so many of you on this call again today, both from the prior call and from our prior conversations on this topic. It's hard to imagine that a year and a half ago, we were so much in a different place, I think, from a personal organizational perspective on this journey. And it has just been a really rich learning for us here at the DuPage Health Coalition, and a fantastic partnership. Really want to credit CJA and RIP Medical Debt for allowing us to be partners in that journey. And I was sitting here and listening to Eva and Lindsay and Gregory and Jessica, and just thinking a lot about the assets that CJA partners bring to this conversation, and really the unique place that we find ourselves in a conversation around medical debt, and why we really are, as donated care network partners and policy advocates and leaders, really the right folks to be engaging in this conversation at this time. And it comes back to that conversation that we were just having about trust, because we sit in this unique juncture oftentimes, in a place where we have relationships with patients, hard earned, that allow us the gift and the luxury of having connection with them, and a degree of familiarity where we may be in a position to hear those stories and to know exactly what challenges they are experiencing. At the very beginning of this journey, when we were deciding whether or not to apply for the opportunity with CJA, we actually launched a survey with our members, because we thought we might have a problem with medical debt. We assumed that our members, because of their income and their insurance status, were likely struggling, but frankly, we'd never asked that question in precisely that way. And the data scared us because it was worse than we thought. And so among the choices that I think folks have on this call, if you haven't asked the question, one of the early steps is that you can invite that dialogue and find out to what extent this is really something that is a pressing need for the families that you serve. But trust is not just about the relationships that we have with our patients, with our members, with our consumers. We also oftentimes enjoy a level of trust with our medical partners that is also unique, and relationships that we work hard to cultivate and preserve. We need those relationships to function at a high level. We depend on those relationships oftentimes to ensure that the families with whom we work can have access to the care that they need. And sometimes that can actually make entering into a dialogue around medical debt feel a little bit fraught, because we want to make certain that we're not doing anything that would jeopardize the relationships. But I can tell you that our partnerships have only been strengthened by our participation in this dialogue, and that in fact, we were able, I think, to advance that dialogue in a way that most of our advocate partners were not, because our healthcare partners oftentimes saw them as well-intended adversaries in that process, instead of as colleagues and partners in that enterprise. Whereas we had 20 years of working together closely in service of patients, and they knew that we were coming into this conversation with a level of collaboration and cooperation and a commitment to preserving that. Today, we have $8 million worth of medical debt that we've been able to address on a individual patient level that we're really excited about. But we also have ongoing partnerships with 2 health systems and more than 10 hospitals that we hope ultimately, with RIP medical debts assistance, will result in impact to many, many thousands of patients, most of whom we will never meet, will never come into our offices, but hopefully will have the ability to have their debts forgiven. And so I just want to, again, highlight what an opportunity this is. Certainly from CJA's perspective and from the Donated Care Network's perspective, but also I think this is just a conversation that is a burning platform right now, and a place where all of us that are on this call, clearly we're interested, clearly we're committed. That's why we're here. That's why we do the work that we do. But also it's not just an interest, it's actually a capacity. We have the ability to do something meaningful to inform this conversation and to advance it. I put my email in the chat, unprompted, uninvited. But if anybody is thinking about considering whether or not their organization might want to dip their toe into the pond of this, if you're another access organization like ours, I just wanted to invite you. Please feel free to reach out to me. Happy to talk more about our experience these last few months and share our learnings. And last, I know, Gregory, that you guys are going to be launching a survey, and I just wanted to lift up the most important thing that everyone that's participating on this call, what we really need to know is what would be most helpful to you, what you're most interested in learning more about in this span of the topic of medical debt, and how CJA and RAP Medical Debt could partner with you to advance your local efforts. What do you need from this partnership to be able to do that work on the ground? That's feedback that would be invaluable to the planning efforts that are underway. So we hope you'll take a few minutes to share that feedback with us.
Thank you so much, Kara. I feel
Thank you.
I'm adding the link. Okay, perfect. Thank you, Sarah. I was like, it was linked in the wrong way. I also, so thank you so much. I wanted to, again, just reiterate, we're sending out the recording of this, and as well as the survey slides, the presentation slides. If you could complete the satisfaction survey, it's just a few questions, and then again, sharing with candor just what's on your mind and what's your thoughts, what would be most useful. We're really eager to continue engaging between now and especially we have the CJA National Conference coming up in May in Albuquerque, New Mexico, where we'll be also RIP will be working with CJA to kind of, again, enliven the conversation on ways that where RIP's work intersects with CJA's mission in trying to, again, reduce disparities and increase care. So please check out the conference. The registration doesn't open for a few weeks, but it's still being primed. And that will also be, again, on the CJA listserv sent out. So without that, I would just want to, again, reiterate my gratitude to the panelists who presented. Thank you, Eva Stahl, and thank you, Lindsay Zickdale. I know that was a lot to take in, but a lot of resources were included as well. I want to appreciate our partners, Access Health and DuPage Health Coalition, for joining us on this call, as well as CJA. Thank you for opening the call. And thank you to all the members and attendees that showed up today and then showed up on the first learning call. We'll be in touch, and we'll, again, be following up at minimum with the slides, and we hope to see you in the new year. Hope everyone has a lovely holiday as well. Thank you all so much.